Delegates interested in hands-on echo workshop can move on to workstation number 1. It's going to be starting soon. Conducted by Dr. Ramrajan sir, cardiologist from Coimbatore. Over to you, chairpersons.
Good morning, everyone. I'm honored to introduce Dr. Selvaraj, who's a renowned diabetologist in Erode, in and around Erode. Many of us would have consulted him, including my family members and all our patients, GDM patients, we have referred to him. And he is known for his patient-centric approach and his follow-up on the patients. And every time we call him for opinions, he immediately responds, and very happy to introduce him here. Over to you, sir. Thank you.
Thanks for the nice word, ma'am. Respected chairpersons and my colleagues and friends, it's a great honor for me to welcome you all again for this hypertension summit. The next 10 to 15 minutes, I will just brush through the hypertensive disorders in pregnancy, because most of the hypertensive disorders in pregnancy is actually managed by our chairpersons rather than us. And I think a lot more will be learned from them also. So it is a hypothetical case study when a 32-year-old primi gravida is on a regular follow-up with obstetricians, has come for a routine visit. And now she is in a 34 weeks gestation. This office reading of blood pressure was 146/94 millimeter mercury. So the obstetrician asked her to wait for 4 hours to take rest and repeat the reading. It showed that 42/90 millimeter mercury. So she has ordered a routine investigation for evaluation. So when we see a obstetric patient with a blood pressure more than 140/90, we come to a diagnosis of hypertension in pregnancy. The classification of hypertension in pregnancy is very straightforward. If a pregnant mother is less than 20 weeks gestation having blood pressure of more than 140/90, it is a chronic hypertension. So the division comes there. When gestational week is more than 20 weeks, we have 3 divisions. Gestational hypertension that may progress to preeclampsia or eclampsia, or already having chronic hypertension which may be having a superimposed preeclampsia. So to diagnose gestational hypertension, it is a sustained rise of blood pressure of 140/90 millimeter mercury or more for at least 2 occasions, 4 or more hours apart beyond 20 weeks. And without proteinuria. When you say patient has gestational hypertension, that blood pressure will be more than 140/90, gestational week is more than 20 weeks, and without proteinuria. Or within the first 48 hours of delivery, postpartum period, in a previously normotensive woman. And that should resolve by 12 weeks of postpartum. That only makes the patient classified as gestational hypertension. Somebody classify this as a transient hypertension. So most of the patient will, almost that 40 to 50% of patients may progress to preeclampsia syndrome. So preeclampsia is a pregnancy specific syndrome. It visually affects every organ in the organ system. It's nothing but a hypertension with proteinuria, that's all. When we call it as proteinuria, it is an objective marker. It actually marks that it has system-wide endothelial leak. So when protein measurement of 24-hour urinary protein excretion more than 300 milligram, or urine protein creatinine ratio more than 3, or when we do a dipstick method, 1 plus protein or persistent 30 milligram per deciliter in a random urine sample, we call it as proteinuria, and hypertension with proteinuria we call it as preeclampsia. So when we look for multi-organ dysfunction, there may be a thrombocytopenia, renal dysfunction, or liver dysfunction, central nervous system involvement, or pulmonary edema. Eclampsia, we know that when pre-eclamptic patient does a convulsion, there is no other reason for convulsion, we call it as eclampsia. The seizure will be generalized, can appear before, during, or after the labor. And we know that chronic hypertension mostly can proceed with preeclampsia, superimposed preeclampsia, because the patient who has hypertension previously before pregnancy, they are more likely to end up in preeclampsia. And compared to pure preeclampsia, superimposed preeclampsia is commonly develops early in the pregnancy and often accompanied by fetal growth restriction. So when we move on to preeclampsia, whenever we have a patient in an antenatal care, we have to look for preeclamptic or hypertensive signs when patient is more than 40 years or older, nulliparity, and pregnancy interval of more than 10 years, and family history of preeclampsia, previous history of preeclampsia, and when they are obese, and pre-existing vascular disease such as hypertension or diabetes, like that, pre-existing renal disease, or twins pregnancies, we have to look for hypertension and preeclamptic stage. So that risk factor we can divide as those patients can have higher risk for preeclampsia, is already having autoimmune disease like systemic lupus erythematosus or antiphospholipid syndromes, chronic hypertension, diabetes mellitus, either type 1 or type 2, history of preeclampsia, previous preeclampsia, multiple fetal gestation, renal disease. When they are 35 years or older, or black race, low socioeconomic status, family history of preeclampsia, these all comes under moderate risk category, body mass index more than 30 and nulliparity, and having a history of low birth weight infant, those things. So why does this hypertension comes in pregnancy or progress to preeclampsia? There are few reasons. One is those exposed to chorionic villi first time. That is because of nulliparity. When they exposed to chorionic villi for first time, they can have, any nulliparity woman can have when they are older or younger, are exposed to superabundance of chorionic villi like twins, hydrodiform mole, or pre-existing endothelial vascular cell activation, inflammation, diabetes, renal, cardiovascular disease, like that. Or if they are genetically predisposed to hypertension, they can develop hypertension during pregnancy. So in etiopathogenesis, fetus is not the prerequisite for preeclampsia. Chorionic villi is the essential thing to develop hypertension and preeclampsia. So preeclampsia syndrome is a characterized by abnormalities in the vascular endothelial damage, which results in vasospasm and transduction of plasma and ischemia and thrombotic sequelae. So if we, there are imposing number of mechanisms. One is abnormal tropoplastic invasion of uterine vessels, immunological maladaptive tolerance of the maternal and paternal fetal tissues, and there is a maternal maladaptation to the cardiovascular or inflammatory changes in the normal pregnancies, or genetic factor including inheriting predisposing genes. So if when there is a tropoplastic invasion, the normal implantation is characterized by extensive remodeling of spiral arteries. So if spiral arteries with the decidua specialis, usually this endovascular tropoplast replace the vascular endothelium and muscular lining to enlarge the vessel diameter. That should not be there because only tropoplast should be there. Whereas in an abnormal tropoplastic invasion, there is an incomplete tropoplastic invasion, which leads to they don't lose their endothelial lining and musculoskeletal, musculoelastic tissues, and their mean external diameter, only half of that is corresponding to the normal placenta. Normal placenta versus the preeclamptic placenta, the diameter will be only half of that. In general, magnitude of the defective tropoplastic invasion is the correlation of the severity of the hypertensive disorders. If there is a higher magnitude, there will be more correlation with the severity of the hypertension. There are immunological factors which says that this paternally derived placental and fetal antigens, the maternal immune tolerance is not there. So that can cause this preeclampsia. It's actually immune-mediated disorder, preeclampsia. For example, risk of preeclampsia is appreciably enhanced in some circumstances where blocking antibodies of the placental antigenic sites might impair the first pregnancy, would carry the higher risk. So, women destined to be preeclampsia, extravillous trophoblast early in the pregnancy expresses reduced amount of immunosuppressive non-classic HLA-G. So there is an endothelial cell activation due to anti-angiogenic and metabolic factor which causes inflammatory mediators which provokes the endothelial cell injury. So cytokines, tumor necrosis factor, alpha and interleukins are all associated with the oxidative stress which causes preeclampsia. Activation of microvascular coagulation manifests thrombocytopenia, and there is an increased capillary permeability which leads to edema and proteinuria. There are some genetic factors. It is actually multifactorial and polygenic disorder. The 20 to 40% of daughters of preeclamptic mothers are developing preeclampsia, and up to 37% of sisters of preeclamptic women can develop this preeclampsia. 47% of twins can develop preeclampsia. This actually denotes that there is a multifactorial genetic factor which involves in predisposition to eclampsia. So, okay, we have a chance of developing preeclampsia. How to detect? So, how to predict that this patient can have preeclamptic syndrome or not? There are a few ways of doing it. I will elaborate in a clinical test that called as proactive pressure test. There are three tests which they generally say that rollover test, which is simple, can be done in clinics. When patient, we can rest them for 5 to 10 minutes in a left lateral decubitus position. Then roll over to the supine position. So first measure the blood pressure when they are in a left lateral decubitus position. Then roll over them, leave them in a supine position for 5 minutes, 2 to 5 minutes. Then take the blood pressure. If it is, the rise is more than 30 millimeter mercury systolic, then it denotes that patient is at risk for developing preeclampsia. The same thing applies for the isometric exercise test. When we give a hand grip for 5 to 10 minutes, and if there is rise in systolic blood pressure more than 30 millimeter mercury, then that patient may develop preeclampsia. This angiotensin 2 infusion test is not done routinely, but it also can show that incremental increase in dose of intravenously, the response to that angiotensin 2 infusion can denote that that patient can go for preeclampsia. And also there are other tests which we can measure by Doppler, uterine artery Doppler velocimetry, where faulty trophoblast invasion of the spiral artery result in diminished placental perfusion, so which causes upstream increased uterine artery resistance, which will increase the Doppler velocimetry. And increased uterine artery velocimetry determined with Doppler first 2 trimester provides indirect evidence for the process and serves as a predictive test for preeclampsia. There is an increased flow resistance which results in abnormal flow pattern, that is exaggerated diastolic notch, can predict that the patient may go for preeclampsia. So what are all the symptoms which we have to take into consideration that the patient is going for preeclampsia? Mainly most of the patients will have severe headache, persistent severe headache, and sudden weight gain. In 1 or 2 weeks, 3 weeks, they gain 3-4 kg weight. And there is an non-dependent edema. Edema occurs in the face, in the hand, and there is a complaint of nausea, vomiting, and there is a shortness of breath when walk for the routine distance, and the presence of protein in the urine. That is more important, as we discussed, that only qualifies as a preeclampsia. And low urine output also, we can take it as a symptoms. So what are all the indicators that this patient is having severe preeclampsia or non-severe preeclampsia? So severe preeclampsia, first is the blood pressure more than 160/110, we call it as severe. When non-severe, when it is less than 160/110. Proteinuria will be positive, and usually in a non-severe preeclampsia there won't be any big clinical symptoms, but in severe preeclampsia will have a headache, visual disturbance, upper abdominal pain due to stretching of liver capsule, and oliguria, increase in serum creatinine, thrombocytopenia, transaminase elevation, fetal growth retardation, and pulmonary edema. Those things are indicator of preeclampsia severity. So okay, how to prevent preeclampsia and preeclampsia severity? There are lot of things have been evaluated. One is dietary manipulation. They say that low salt diet can have some effect on progress to preeclampsia. Then calcium, giving more calcium, and fish oil supplementation, exercise, cardiovascular drugs, antihypertensive drugs, and antioxidants, vitamin C and vitamin D and E, and antithrombotic drugs like aspirin and all we can try in preeclampsia. That will take. This is one of the beautiful slide which is taken from NEJM. If we see that the moderate exercise 140 minutes per week actually reduces 40% reduction in preeclampsia. I will pass up few things. Because I'm lack of time. And another thing is, if we initiate aspirin before 16 weeks, 60% reduction in preterm eclampsia. And intake of excess calcium, that means supplementing calcium, reduces 50% reduction in preeclampsia and timed birth. So as I told, the aspirin prophylaxis before 16 weeks, that 11 to 14 weeks, it reduces prevention of preeclampsia. This is all the guidelines, clinical risk factor. So where we have to give recommended aspirin like previous history of preeclampsia, multiple gestation, chronic hypertension, diabetic patients, renal disease patients. These are all patients which needs to be given aspirin beforehand. And moderate, only patient who are having uncomplicated full-time delivery, no other complication, we need not give aspirin. So how to manage them? Early identification of worsening of eclampsia, development of management of plan is timely delivery. Those things are important. We have to do a detailed examination, history, weight determination daily, analyze protein, blood pressure reading, serum creatinine, evaluation of fetal size. All the things we have to manage. So these are all the things which we have to see. Basic management is termination of pregnancy with the least possible trauma to mother and fetus, birth of an infant who subsequently thrives, and the complete restoration of the health to the mother. So this is the drug which we need to give to reduce hypertension. So when non-severe hypertension is there, the first choice is labetalol, 100 to 200 milligram, 3 to 4 times daily we can give. The maximum dose is 1200 milligram. Next choice is nifedipine, 10 to 20 milligram. The maximum is 120 milligram. Methyl dopa, nowadays we are not getting it. But 250 to 500 milligram 3 times a day is a wonderful drug in preeclamptic patient, but we are not getting. But when there is a severe hypertension, we have to think about giving labetalol as an IV. When there is more than 160, 110, there is an imminent eclampsia, then we have to reduce the blood pressure. We have to give IV labetalol, initially 10 to 20 milligram. It can be repeated every half an hour with the incremental dose for 20 to 40, then 40 to 80 milligram we can give. Then we can start an IV infusion as 0.5 to 2 milligram per minute. It can be given as orally also. It can repeated every hour to see whether patient is responding or not. We can use nifedipine 10 milligram as an oral tablet, and hydralazine is another important drug which can reduce blood pressure fantastically. It can be given intermittently 5 milligram as a bolus, then followed by every half an hour. It can be repeated. So methyl dropa, as I said, it is not available. The consideration for the delivery, because termination of the pregnancy is the only cure for preeclampsia. Headache, visual disturbance, oliguria and epigastric pain are ominous signs. Severe preeclampsia demands anticonvulsion, antitherapy followed by delivery. Goals of treatment is to forestall the convulsion, to prevent intracranial hemorrhage, serious damage to the vital organs, and deliver a healthy newborn. Consideration for the delivery: moderate to severe preeclampsia does not improve after hospitalization. Delivery is advisable for the welfare of both mother and fetus. So labor induction is carried out usually with the pre-induction cervical ripening. Whenever it is appeared, induction is almost certainly will not succeed. If you are thinking that the induction will not succeed, we can straight away proceed towards cesarean delivery. I will go through the eclampsia. Eclampsia, because when patient has seizure disorder with the preeclampsia, we call it as eclampsia. Magnesium sulfate is highly effective preventing convulsion. So goal of treatment will be to control the convulsion with magnesium sulfate and intermittent administration of antihypertensive medications to lower the blood pressure. We should avoid diuretic unless otherwise there is an obvious pulmonary edema. Delivery of the fetus will achieve the remission of the preeclampsia. So 2013 task force recommends that the woman with either preeclampsia or the severe preeclampsia should be given magnesium sulfate as a neuroprophylaxis. Well, mild preeclampsia does not require any neuroprophylaxis. So magnesium sulfate controls the convulsion. It's not for the hypertensive control. This actually controls the convulsion because it is a very effective drug to control the anticonvulsion. Does not cause any depression in the mother or infant. So it is a more preferable one. And this is the guideline which says that we have to give 4 to 6 gram of loading dose of magnesium sulfate in a 100 ml of IV fluids administered over 15 minutes, and followed by we can give a 2 gram per hour as an IV maintenance. And when we are giving IV magnesium sulfate, we have to monitor the magnesium toxicity also. We have to assess the tendon reflex. So it can be given as IM also. When somebody is in the periphery, then they cannot administer it as IV infusion. Then they can give a bolus dose in IV and they followed by an 5 gram of magnesium sulfate in each gluteal region, upper gluteal regions. It can be repeated at a interval by seeing with the response to the drug. So magnesium sulfate toxicity we have, because 4 to 7 milliequivalent per liter will arrest the convulsion. If the magnesium level goes beyond 10 milliequivalent per liter, the petrolal reflex will disappear. So it is a warning sign of magnesium toxicity. So we have to assess the deep tendon reflex. So when there is an toxicity, we can treat it with a calcium gluconate 1 gram intravenously and withhold the magnesium sulfate. Usually it will reverse that. So this serious complication of severe hypertension, for want of time I didn't go through all of this. Placental abruption, HELLP syndrome, pulmonary edema, renal failure, eclampsia, that what we have seen, and hypertensive encephalopathy, ruptured liver hematoma, and more importantly, perinatal maternal death can occur. So, word about fluid therapy. Ringer lactate solution can be administered around 60 ml, no more than 125 ml per hour, unless otherwise there is a fluid loss from vomiting, diarrhea, and diaphoresis, or excessive blood loss. Because patient has oliguria, don't attempt to give more IV fluids. The conservative fluid admission is preferred in severe preeclampsia who already have an excessive extracellular fluid inappropriately distributed. So by giving more large volume will lead to maldistribution of extravascular fluid and will lead to pulmonary edema and cerebral edema. Thanks for your patient hearing.
In early pregnancy, essential hypertension, which is the best drug to start? Around 6 weeks, 7 weeks pregnancy with hypertension.
The guideline says that we have to start with labetalol, and we can add on to a nifedipine if we are not getting good control. So beta blocker with the calcium channel blocker usually gives a good control. Diuretics comes very last. We can start with any other experience from you, madam?
No, sometimes it may cause us IUGR, they are telling, sir, if we are starting beta blocker early. But no other choice.
Yeah.
Congratulations, Dr. Selvaraj, sir. You have wonderfully presented what could be the nightmare for both the obstetrician and physicians, gestational hypertension. So my question is, as we have gestational diabetes, we used to follow them for future diabetes. In case of gestational hypertension, whether we need to follow them for future hypertension?
Yes, definitely.
If so, how often we should follow, sir?
Actually, the guideline is that they have to follow up every 6 months to 1 year. And when they are having an genetic factor like family history of hypertension, they used to have more regular follow-up, more frequently also.
The next question is use of IV labetalol in case of gestational hypertension. Most of the time we get a call from obstetrician saying that we are on the full dose of oral antihypertensives. So are we justified to use even in the cases of gestational hypertension which are less than 160 but not under the control, sir, with the full dose of oral antihypertensives like labetalol and nifedipine?
Actually, goal of controlling severe hypertension is less than 60 by 110. The recommended goal, not much. But when we are having a higher blood pressure which is not getting controlled, we can add on another hydralazine like that.
Can we use IV formulation?
Yeah, hydralazine we can use.
Thank you, sir.
Thank you, sir. Thank you for the demystifying what is often considered one of the most challenging topics for any obstetrician. With enhanced knowledge on gestational hypertension management, I'm sure we all can reduce maternal morbidity and mortality. Now it's time to honor our speaker. May I ask our chairpersons to please hand over the memento to our speaker. And may I request Dr. Meenakshi Gaurishankar ma'am to hand over the mementos to our esteemed chairpersons. Dr. Prem Kumari ma'am, Dr. Sumati Padmanabhan ma'am, Dr. Priya ma'am, and Dr. Naveen Kumar sir. Thank you very much, dignitaries. you.